there is a pathway, a molecular pathway, in that there is the liberation of metalloproteinase who destroy the dermis. And this metalloproteinase exists in all the human beings and works for recovering some tissue that is damaged. But there is a balance, and in this case, seems to be an imbalance in that there is more metalloproteinase and less inhibitors. So this destroys the dermis and cause a loss of collagen and elastic fibers in the dermis, and this produce clinically these holes, these scars atrophic in the face. Could be in the chest, but in the chest there is another possibility that is hypertrophic keloids, or in the back there is atrophic or hypertrophic, depends, but in the face is more common, the most common clinical presentation, atrophic scars. When we use antibiotics, we are avoiding inflammation. When we avoid inflammation, we avoid metalloproteinase liberation. So in the moment that we are giving the standard treatment, we are avoiding inflammation and we are avoiding liberation of metalloproteinase, and we are avoiding the development of atrophic scars. But if we want to go indeed, we have to stop the genes, so to block the genes who liberate metalloproteinase in these patients and to avoid totally the presence of scars. But we don't have in this moment exactly where are these genes. There are some studies that there is the hypothesis that these genes could be in the FOXO1 and FOXO3 area that control the metalloproteinase liberation. But maybe in the future we can develop some target therapies for this area of the nucleus, for example. The point is destroy the skin. If you destroy the skin, you provoke regeneration. And the regeneration is related now with stem cells from the bone marrow of some group of stem cells that comes from the skin that are sleeping very close from the sebaceous gland, and these stem cells activate and form new collagen and fibroblasts, but there is another group of stem cells who comes from the bone marrow, and these recover the skin. So any method that you select will improve the appearance, but never recover 100%. It's very difficult. You have to repeat the treatments, the surgical treatments, and there are new regenerative tendencies. For example, the plasma-rich platelets-rich plasma, that some people say that if you inject this under the skin, improves the appearance of the scars, but we need to do more research in this field. There are almost anecdotic papers. You can see maybe 10 patients, 5 patients who did some ablative lasers, for example, and apply PRP. But we know that only with the damage to the skin, we are developing some pathways for regeneration. So apply PRP could be, maybe we need half phase with PRP, half phase without PRP. We need more studies about it. But if you have ablative therapies, you will recover some percent of the appearance of the patients. In acne, all the time we speak about physiopathology, sequelas, scars, and therapeutic possibilities, but there is very little research in relation with genetic of acne. I think one field that should be more stronger is the research in genetics of this disease. The genetic of the patients with acne without scars, who is not prone to develop scars, and the patient who is prone to develop scars. Inclusive, there is patients with terrible acne, very severe, related with other disease like hyperosteitis, pyoderma gangrenosum, but these patients could be a totally different genetic background. So this is a spectrum of the possibilities, and I'm sure it's a polygenic disease. So it's needed a big research in this field.